A case laid with metabolic challenges and procedural considerations. We have an obstetric jaundice patient posted for ERCP. To guide us, we invite Dr. Rashmi Ravindran from Government Medical College, Kozhikode, and Dr. Sheila Varghese, Professor, Department of Emergency Medicine, SUT Medical College, Trivandrum.
We have Dr. Gloria John and Dr. Ammu Anjali Sajeev from Government Medical College, Kozhikode, to present this case. Let's explore coagulopathy, sepsis risk, sedation choices, and post-procedure care.
Good morning all. Dr. Ammu and Dr. Gloria from postgraduate students from Calicut Medical College will be presenting a case of obstructive jaundice coming for ERCP procedure. So, you can start.
Presenting a case of obstructive jaundice for ERCP. A 67-year-old male patient, Hamid, who is a manual laborer from Vadagara, presented to surgical OPD with a history of abdominal pain for 1 month, yellowish discoloration of eyes and urine for 2 weeks, generalized itching for the past 10 days. History of present illness. Patient was apparently normal till the onset of abdominal pain 1 month back. Pain was gradual in onset, colicky type of pain, intermittent in nature. Pain was generalized to the whole abdomen but more in periumbilical region. Pain was non-radiating and aggravated by food intake with no relieving factors. Yellowish discoloration of eyes and urine was gradual in onset and progressive in nature through the last 2 weeks. Itching was gradual in onset, generalized and progressive in nature, relieved on taking medication for the past 10 days. On probing, patient elicited that his stools were bulky and clay-colored. No history of abdominal distension or abdominal lump, no history of vomiting, loss of appetite, loss of weight, no history of fever, chills, rigors, no history of bleeding from gums, hematemesis, hematuria, EC bruisability, no history of altered behavior, gynecomastia, loss of libido, loss of hair, reversal of sleep rhythm, no history of breathlessness, chest discomfort, swelling of legs, no history of dysuria, nocturia, polyuria or polydipsia, no history of visual disturbances, muscle weakness or bone pain. Past medical history, no history of blood transfusion, travel to outside, drug intake or tattooing. No history of diabetes mellitus, hypertension, coronary artery disease, cerebrovascular accident, chronic kidney disease, chronic liver disease, bronchial asthma, chronic obstructive pulmonary disease, seizures, dyslipidemia. No history of prior surgery or anesthesia exposure. No history of autoimmune disorders. No history of any recent upper respiratory tract infection. No history of allergy to iodine or shellfish. Personal history is a married man with 2 children, follows mixed diet, and there are no history of any addiction. Sleep, appetite, bladder habits were normal. No history of any drug or food allergies. Family history, no history of similar illness in the family, no history of malignancies or chronic illnesses in the family, no history of autoimmune disorders in the family. Occupational history is the earning member of the family, is a manual laborer. Treatment history, patient is on 2 medication given from the hospital following admission, no history of intake of any chronic drugs or herbal medicines, and he belongs to a lower middle class family.
And on examination, general examination, he was conscious and oriented. He has a weight of 50 kg, height is 164 centimeter with a BMI of 18.5 kilogram per meter square. There is icterus present on sclera and nail beds. Multiple scratch marks are present on the abdomen. There is no clubbing, cyanosis, lymphadenopathy, pedal edema. There is no signs of any liver failure like thinning of hair, fetor hepaticus, perotidomegaly, spider angioma, palmar erythema, ecchymosis, hyperpigmentation, Dupuytren's contracture, asterixis, gynecomastia, testicular atrophy or loss of body hair and ascites. He is afebrile. Pulse rate was 68 per minute, regular, normal in volume and character. There was no blood vessel thickening, no radiofemoral delay, bilateral pulses equal and palpable. Blood pressure was 140/80 mm of Hg in the right upper limb in sitting position. Respiratory rate was 14 per minute, regular and abdominothoracic. Saturation is 98% on room air. JVP was not visible. On airway examination, there was no facial asymmetry. Mouth opening was 5 cm, Malambo class 3. Thyromental distance 7 cm. Temporomandibular joint insinuates one finger. Upper lip bite test was class 1. Neck movements within normal limit. There is no loose tooth or artificial dentures. On examination of gastrointestinal system, upper GI tract showed good oral hygiene. There was no fetor hepaticus, no macroglossia, loose tooth, artificial dentures or enlarged tonsils. There was no postnasal dripping, no congestion. On inspection, abdomen was scaphoid with empty flanks. All quadrants move equally with respiration. Umbilicus was central and inverted. Skin is normal, but scratch marks were present on abdomen. There was no visible mass, dilated veins or pulsations. External genitalia and hernial orifice was within normal limits. On palpation, there is no local rise of temperature, no tenderness, no gourding or rigidity, no rebound tenderness. Liver was palpable 2 cm below costal margin, firm in consistency, border was sharp and non-tender, no other masses felt. On percussion, tympanic resonance noted in all quadrants, liver dullness present at right 5th intercostal space in the midclavicular line. Liver span is 12 cm. There is no splenic dullness, no shifting dullness, no puddle sign. On auscultation, normal bowel sounds heard. There is no venous hum or bruit. Cardiovascular system, pulse rate was 68 per minute and regular. BP was 140/80 mm of Hg in right upper limb in sitting position. Apex beat was felt at left 5th intercostal space medial to midclavicular line. S1, S2 was normal without any murmur. And central nervous system, he was conscious oriented. Higher mental functions were intact. Cranial nerves were intact. Motor system was with normal bulk, tone and power was 5 out of 5 in all limbs. Sensory system intact and deep tented reflexes were normal. Respiratory system had normal vesicular breath sounds heard on all areas, which was equal in intensity. There was no added sounds and no use of any accessory muscles.
Okay. Can you tell me your positive findings in the history, first histories?
This is a 67-year-old patient with abdominal pain, jaundice, generalized itching, pale, bulky stools which points towards obstructive jaundice. And there is also jaundice present on the sclera and urine, and there will be scratch mark present on the abdomen.
So you said something about abdominal pain, What does it indicate?
Probably the cause can be probably due to an extrahepatic biliary obstruction. Abdominal pain indicate more towards any cholangitis or cholecystolithiasis, like stone benign causes.
Yeah, infective causes or inflammation.
Yes,
Inflammation leads to colicky pain, right? And what about the other causes? Painless. When do you get painless jaundice without abdominal pain? Usually.
Other causes include malignant causes like gallbladder carcinoma, cholangiocarcinoma, periambulary carcinoma. Usually does not present with pain.
Okay. Then what about the examination? What are the positive findings in your examination?
In the examination, general examination, there was icterus present on the sclera and the urine, and there were scratch marks present on the abdomen, and there was no palpable gallbladder.
Okay, then urine. What about the color of the urine?
Urine was also high colored, yellow colored urine.
That was in the history. Okay. So can you summarize your findings based on diagnosis?
He's a 67-year-old male patient with abdominal pain, jaundice, yellowish discoloration of the sclera and urine, generalized itching. On examination, there was yellowish discoloration of the eyes and urine.
Okay.
Scratch marks were present in the abdomen. Vitals were within normal limits, and systemic examination were within normal limits. So diagnosis is an obstructive jaundice patient with no features of portal hypertension or hepatocellular pathology, dysfunction, posted for ERCP.
Okay. So how can you differentiate between the other causes of jaundice, and what are the other causes of jaundice based on symptoms and what investigations?
Jaundice can be classified due to hemolytic jaundice, hepatocellular jaundice, or obstructive jaundice. Hemolytic jaundice occurs mainly due to the breakdown of RBCs. Patient may give history of anemia, transfusion, fatigue, hematoma. and there will be no history of generalized pruritus or yellow color urine. Urine will be acholoric. On investigation, there will be unconjugated hyperbilirubinemia. ALT, AST, LP will be normal. There may be increased lactase dehydrogenase. Peripheral smear may be abnormal. In urine, there will be increased urobilinogen and absent urine bilirubin. In hepatocellular jaundice, it occurs due to hepatic pathology, hepatic injuries. Patient may give history of viral hepatitis, hepatotoxic drugs, alcohol intake, gives history of anorexia, nausea, right upper quadrant pain. Urine will be yellowish colored, and on examinations there will be mixed hyperbilirubinemia. ALT, AST will be markedly elevated. ALP may be normal or mildly elevated. In urine there will be increased urine urobilinogen and also increased urine bilirubin.
Okay.
In obstructive jaundice, it occurs due to the obstruction of pathway of bile from hepatocytes to duodenum. Patient give history of jaundice, generalized itching, pale bulky stools. Then on investigation, there will be conjugated hyperbilirubinemia. ALT, AST may be elevated. ALP will be highly elevated, and other enzymes like gamma glutamyl transferase and 5' nucleotidase will be increased in obstructive jaundice. GGT is more sensitive, whereas 5' nucleotidase is more specific. In urine examination, there will be increased urine bilirubin but absent urine urobilinogen.
Okay. So, can you say something about how bilirubin is formed in the body?
So 80% of the bilirubin is formed from the disintegration of the heme, which is coming from the senescent RBCs, and the remaining 20% comes from the other heme containing proteins like myoglobin and cytochromes. So this heme is acted upon by the heme oxygenase, which forms biliverdin, and this is acted upon by the biliverdin reductase, which forms bilirubin. And this bilirubin is lipid soluble or water insoluble, which forms a complex with albumin, and this complex is transported through the plasma and it reaches the liver. It is taken up by the hepatocytes and undergoes glucuronidation by UDP glucuronil transferase enzyme, resulting in the formation of bilirubin 1 glucuronide, monoglucuronide, and bilirubin diglucuronide, which is the conjugated bilirubin, and it is water soluble, and it will be excreted actively into the bile duct. So initially it reaches the biliary canaliculae. From there it reaches the intersegmental or interlobular ductules, and then the right and left hepatic ducts, then the common hepatic duct, which joins with the cystic duct, reaches the common bile duct, and then it reaches the second part of the duodenum through the ampulla of water. So this is the rate limiting step in the bilirubin formation. Then it reaches the terminal ileum, and it is oxidized by the intestinal bacteria, and then it forms urobilinogen. 80% will be converted into stercobilinogen, which is oxidized to stercobilin, and this will be excreted through the fecal matter. And the remaining portion, it enters the systemic circulation, and then it is reaching the kidneys, excreted in the form of urobilinogen. So this is how bilirubin is formed.
So, what is actually bile? What is the composition of bile?
Bile is a colorless isotonic aqueous solution which has a pH of about 7.8 to 8.6, and the composition 97% is water. It also contains cholesterol, bile pigments, bile acids, bile salts. Then it contains fats, fatty acids, and phospholipids. So bile acids are primary and secondary. Primary bile acids are formed in the liver from cholesterol, and this is acted upon by the intestinal bacteria, forming the secondary bile acids. The primary bile acids are cholic acid and quinodeoxycholic acid, and secondary bile acids are lithocholic acid and ursodeoxycholic acid. Both of these will be acting with the secondary bile acids will form complex with glycine and taurine, and it will then result in the formation of bile salts.
Okay. So, what is enterohepatic circulation of bile acids?
In enterohepatic circulation, the bile which is reaching the terminal ileum, it will be reaching the systemic circulation, and through the portal vein it reaches the hepatocytes, and there it is again reused and recycled in such a way that the bile is utilized. So that is enterohepatic circulation.
What are the functions of bile?
It helps in emulsification of fat and aids in the absorption of fat. It helps in the absorption of fat-soluble vitamins like vitamin A, D, E, K. Then it makes the duodenal pH alkaline. Then it helps in the excretion of bilirubin and excretion of excess cholesterol from the body, and maintains the intestinal permeability and maintains the intestinal bacterial flora.
What can you name some drugs which are excreted through the bile?
Drugs like vecuronium, rocuronium will be excreted through the bile.
Okay. So any drug which can cause obstructive jaundice, can you think?
Cholestasis producing drugs like antibiotics like erythromycin, clarithromycin, then oral contraceptive pills can produce cholestasis.
And anabolic steroids?
Anabolic steroids.
Okay. Okay, so pathophysiology.
Can you say the pathophysiology of this obstructive jaundice?
Obstructive jaundice occurs due to the obstruction of passage of bile from the hepatocytes to the duodenum. So this results in cholestasis and increased biliary pressure, resulting in the rupture of biliary canaliculi into the sinusoids. Due to cholangiovenous reflex, cholangiolymphatic reflex, and paracellular leakage, this bile then reaches the systemic circulation.
Okay.
So, the features of the obstructive jaundice are due to the absence of bile in the intestine and due to the increased bile in the systemic circulation.
Yes.
In gastrointestinal system, due to the absence of bile, there will be decreased absorption of fat, resulting in steatorrhea, decreased absorption of fat-soluble vitamins like A, D, E, K, and due to the absence of vitamin K, it can affect the coagulation factors, vitamin K dependent factors that are 2, 7, 9, 10. And due to the absence of bile, there will be increased bacterial proliferation in the intestine, resulting affect the intestinal barrier, resulting in bacterial translocation into the systemic circulation and endotoxemia. This results in nitric oxide synthesis and peripheral vasodilatation. Then in the cardiovascular system, due to the it has got negative inotropic and negative chronotropic effect. It has got direct electrophysiological depression activity. It depresses the SA node, increase the vagal tone, decrease the number of beta receptors in the cardiac membrane, and there is nitric oxide cause peripheral vasodilatation, which result in decreased systemic vascular resistance. This all contributes to bradycardia and hypotension, which exaggerate during anesthesia.
There is reduced beta receptors
In
and
the
sensitivity is also reduced. What is this term known as? Like the effect of all this on cardiovascular?
Heart is known as the jaundice heart.
Jaundice heart or bilirubin cardiomyopathy.
In the renal system, it was direct tubular damage, and due to bilirubin cast, it can result in acute tubular nephritis. And due to peripheral vasodilatation, there is decreased blood volume, resulting in decreased renal perfusion and decreased glomerular filtration rate. And due to renin-angiotensin aldosterone dysregulation, this also contributes to renal vasoconstriction and decreased GFR. In immunological system, due to the absence of bile, there will be bacterial proliferation in the intestine and endotoxemia, and there will be Kupffer cell dysfunction, resulting in decreased immunity. In hematological system, there will be anemia of chronic disease, and there may be coagulopathy due to vitamin K dependent factors 2, 7, 9, 10. Absence of vitamin K, absent activation of vitamin K dependent factors, that is 2, 7, 9, 10.
What is this vitamin K required for? Why does
It
it
requires for the gamma carbonylation of glutamic acid terminals in the N terminals of the amino acid for the activation of factors 2, 7, 9, 10, protein C and protein S.
So can this obstructive jaundice lead to damage of hepatocytes?
Yes, ma'am. Due to increased biliary pressure, it can result in biliary canalicle rupture and hepatocyte rupture, leading to fibrosis, reticulin formation in severe cases.
So it can lead to it can inhibit the cytochrome P450 enzyme systems, leading to accumulation of free radicals and oxidants, which can cause damage to the hepatocytes. So long-standing obstructive jaundice can lead to biliary cirrhosis. Okay. And what about this proliferation of the bacteria in the intestine? Can it cause ascending cholangitis?
It can, due to the bacterial proliferation, it enters the systemic circulation.
Normally, the transfer of bacteria from the papillae duodenum to the biliary system does not happen. But when there is bacterial proliferation, this can lead to ascending cholangitis by transferring the bacteria from the sphincter of Oddi to it can reach the biliary system. Okay. So your patient is having obstructive jaundice, is come for And what are the causes for obstructive jaundice? Can you enumerate what are the different types of obstructive jaundice?
Causes can be intrahepatic and extrahepatic causes.
Okay.
Intrahepatic causes include hereditary disease like Dubin-Johnson, Rotter syndrome, cholestasis of pregnancy, recurrent cholestasis, primary biliary cirrhosis, primary sclerosing cholangitis. Then extrahepatic causes are benign causes and malignant causes. Benign causes include cholangitis, cholelithiasis, then malignant choledochal cyst, biliary stricture. Malignant causes include gallbladder carcinoma, cholangiocarcinoma, periambulary carcinoma.
Okay. So investigations. What are the how will you investigate this case?
I'll do a complete blood count, including hemoglobin to look for anemia, total count for infection, leukocytosis, and platelet to look out for thrombocytopenia. In liver function test, total bilirubin and direct bilirubin to assess the severity of jaundice, ALT, AST to assess the hepatic dysfunction, ALP will be increased in obstructive jaundice, and in obstructive jaundice we can also go for gamma glutamyl transferase and 5' nucleotidase. Then total protein and albumin to assess the synthetic function, PTNR, ABTT to rule out coagulation as the vitamin K dependent factors are affected. Then renal function test, urine routine examination to look for increased urine urobilinogen and increased urine bilirubin. Then other tests like serum electrolytes, blood sugar, blood grouping, serology, chest X-ray, ECG should be done. And to diagnose the condition, we can go for ultrasound, abdomen. To know the extent and the site of obstruction, we can take a contrast enhanced CT.
So do you have the investigation report of this patient? Just go through, just read the investigations that is.
Blood investigation, HB is 13.4 gram per deciliter, total count 7160, platelets 2.36 lakhs per microliter. In LFT, total bilirubin is 12 milligram per deciliter, direct 7 milligram per deciliter. SCOT is 202 international IU per liter, SGPT is 309 IU per liter, ALP 265 IU per liter. Total protein is 7.1 gram per deciliter, serum albumin is 3.6 gram per deciliter, and other investigations are normal. In urine routine, there is increased urine bile pigments and absent urinary urobilinogen. Chest X-ray and ECG are normal. In contrast, CT, in USG abdomen, there are features of cholelithiasis with intrahepatic biliary dilatation. In contrast CT, there is a hyperdense calculus measuring 18 to 6 millimeter is noted in the distal common bile duct. Common bile duct is dilated, measuring 12 millimeter in diameter. Prominent intrahepatic biliary radical dilatation present. Gallbladder is distended with mild wall thickening. No evidence of pancreatic mass lesion. Impression, distal CBD calculus with upstream biliary dilatation.
So this is a case of choledocholithiasis. So patient is posted for ERCP. What is actually ERCP?
ERCP is endoscopic retrograde cholangiopancreatography. It's a combined endoscopic and fluoroscopic procedure which is used for visualizing the anatomy of the hepatobiliary pancreatic system, and also we can diagnose as well as we can do therapeutic interventions. So in this procedure, a side viewing duodenoscope is introduced through the mouth into the esophagus, stomach into the second part of the duodenum, and then ampulla of water is identified, and we'll selectively cannulate by using a catheter or a sphincterotome. A dye which is usually water-soluble iohexol is injected, and by using fluoroscopy, we'll be visualizing the entire anatomy of the duct. And for insufflation, for visualizing the gastrointestinal tract, we'll be using carbon dioxide. But air is also used in some institutes, but it is not preferred because it can cause venous air embolism. So carbon dioxide is much better.
Okay, and it causes much pain also. Post-operatively, the patient will have much pain because the gases, air distends the GIT. Okay, while carbon dioxide is easily absorbed, okay. So what are the indications? What are the indications of ERCP?
Indications can be both diagnostic and therapeutic. So diagnostic for diagnosing the presence of sphincters, narrowing of the bile duct or pancreatic duct, for detecting the presence of gallstones or stones in the bile duct, then checking the presence of malignancies like periambular carcinoma, CA head of pancreas, then cholangiocarcinoma, CA gallbladder. And therapeutic indications are for sphincterotomy, for gallstone removal, then for stent placement, for balloon dilatations and so on.
Okay.
What are the contraindications for ERCP?
Structural anomalies of the esophagus, stomach, duodenum, any altered surgical anatomy. There are patient has contrast dye allergies, iodinated dye allergies, and then
What about the coagulation parameters?
sphincterotomy.
What about the coagulation parameters? If it is deranged, is it contraindicated?
Yes, ma'am. If the coagulation parameters are deranged, ERCP is not indicated.
Okay. So, what are the anesthetic techniques for ERCP?
Based on the complexity of the procedure, patient factors and endoscopic preference, ERCP can be done under monitored anesthesia care and general anesthesia with endotracheal intubation and controlled ventilation.
Now, what are the recommendations, actually standard recommendations for doing ERCP?
The safety standards.
standards.
So in a pre-op day, we'll have to make a thorough check to the ERCP suite and make sure the machine, monitor, the resuscitation drugs, the basic anesthesia drugs and the airway equipments, everything is well arranged. And on the day of ERCP, an anesthetist along with a skilled anesthesia technician has to be present. Then we have to follow the WHO safety checklist. Then the presence of standard ASA monitoring must be ensured and a proper post-anesthesia care unit must be present for adequate recovery of the patient.
And proper pre-anesthetic checkup also should be done for the patient.
Yes.
Okay. Now, this is actually NORA, no? Non-room operating room anesthesia. So, what are the challenges that anesthesiologist faces in NORA?
In NORA, first of all, the operating room will be remote and the anesthetist will not be much familiar with the operating room because it might be a new place for us. Then we have less help available because the major operation theaters might be far away. Then sometimes there will be less room available for us because there is large bulky instruments for both fluoroscopy, anesthesia equipments, endoscopy equipments might be there. Then the presence of the basic resuscitation equipments might be decreased. And in the case of if it's an ERCP procedure, there is increased exposure to fluoroscopy also and we'll be wearing the lead aprons. So these are the main challenges as a non-operating room anesthesia that we'll face.
So actually, you should not compromise. You should have to keep everything ready. That equipments, drugs, monitors, whatever is, you should not compromise on that. And you must make extra stocks also. Sometimes your equipment may not work. So you must see that you have extra. Drugs also, all ACLS, drugs for airway, cart, all emergency as well as equipments, drugs and equipments should be present. You cannot compromise on that. Okay.
Yes, ma'am.
What are the other anesthetic challenges other than this NORA?
So patient-related concerns regarding the age of the patient, most of them will be elderly and the ASA status can be grade 3 and 4 which is a challenge for us. Then disease-related concerns, because of cholestasis, the excretion of the biliary excretion of the drugs will be limited like vecuronium, rocuronium, and because of decreased albumin, the drugs will be less bound to albumin, increasing the free fraction of drugs like benzodiazepines, thiopentone sodium, increasing the drug duration of action. And if there is hepatic dysfunction, the metabolism and excretion of those drugs will be affected. And in cardiovascular system, already the patient is having bradycardia and there is decreased beta adrenergic receptor sensitivity. So after induction, there is increased chance of hypotension and it will be difficult to manage because they are less sensitive to catecholamines. And in renal system, already they will be having acute tubular necrosis, which makes them more prone for developing acute renal injury, and we'll have to avoid the nephrotoxic drugs. And the procedure-related concerns, it's a shared airway procedure. So there is less access for us anesthetists during the after positioning or during ERCP if there is any complication arising. And also there is chance of increased extubation and kinking of the endotracheal tube. Then since we are using this water-soluble iodinated dyes, there is chance for anaphylaxis. Then increased exposure to fluoroscopy is possible. Then since the procedure is done in a prone position or lateral position, more chance of pressure nerve injuries, pressure sores are present. Then if it is a sedation procedure, if it is If there is increased sedation, there can be hypoventilation and hypoxia for the patient. So these are the
And
challenges.
radiation also you told now, problems of radiation.
Radiation.
Okay, then what are the indications for this? You said it can be done under two ways, with monitored anesthesia care or general anesthesia with endotracheal intubation. How will you decide what patients to do for monitored anesthesia care?
So if it is a short diagnostic procedure and if the patients are of ASA class 1 and 2 and if we have an experienced endoscopist, we can go for a monitored anesthesia care.
Yeah.
But if we have a patient who is morbidly obese with a difficult airway, uncooperative patient or pediatric patient with a failed sedation, and if the procedure is therapeutic, more complex, long duration with increased chance of bleeding, or if he is an ASA grade 3-4, we can go for a general anesthesia.
Okay, so what are the drugs that are used for, now suppose, let us discuss about the monitored anesthesia care. What are the drugs that is commonly used?
We can use propofol, dexmedetomidine, ketamine, fentanyl for monitored anesthesia care.
Why do you use propofol? Why not sodium thiopentone?
Propofol has got a rapid onset of action within 30 to 45 seconds. Rapid recovery, therapeutic half-life is around 10 minutes. So it helps in faster patient turnover and reduced recovery room stay. It also has got anti-emetic property. It reduces the stress response well and it can get an adequate level of sedation.
Okay, so problems? What are the problems?
Causes pain on injection and can result in hypotension.
Okay, ketamine, what about ketamine?
Ketamine has got a rapid onset and it has got analgesic properties. However, it causes emergence delirium, increased airway secretion and also preserves airway reflexes.
But it has the advantage of maintaining stable hemodynamics that
Stable
increases the
hemodynamics.
heart rate and blood pressure. Okay, then what about the other drug that you told, dexmedetomidine?
Dexmedetomidine has an analgesic property, so we can decrease the dose of opioids, and it can produce a sleep which is resembling natural sleep, and it even preserves the spontaneous ventilation. So dexmed can also be preferred.
What is the problem with dexmedetomidine?
Onset of action is a bit delayed, and it can also produce hypotension and bradycardia in an already a patient who is having bradycardia.
What is the problem with fentanyl and ERCP? Is there any specific issue?
Yes, opioid can result in transient sphincter of aorta dysfunction. This poses difficulties for the endoscopist to cannulate the sphincter.
How will you manage that if the patient is, if the surgeon is saying that there is sphincter of aorta spasm, I'm not able to cannulate?
We can give IV Buscopan 20 milligram.
Okay. Then can you say how you are going to take up the case under monitored anesthesia care, your patient? You have advised all the, Nilpar orally and anxiolytics have been advised. Now on the day of surgery, how you are going to manage?
In the preoperative day, after explaining to the procedure to the patient and obtaining a written informed consent, I'll advise Nilpal order 8 hours for solid, 2 hours for clear fluids, aspiration prophylaxis with tap antiopressol 40 milligram IV, tap metoclopramide 10 milligram, then anti-anxiety, tap alprazolam.
Done, everything done. Patient is brought to the OT on the.
In the day of the surgery, after making sure the OT is prepared with machine monitors, suction, airway equipments, emergency drug, the patient is brought into the OT. I'll attach standard ASA monitors including ECG, NIBP, pulse oximetry, EGCO2. Then I'll secure an 18 gauge IV cannula, ringer lactate is given. Then I'll spray the throat of the patient with 10% lignocaine spray. I'll ask the patient to lie in prone position.
Give IV. Glycopyrrolate also, injection glycopyrrolate.
Injection glycopyrrolate 0.2 milligram IV. Then I'll ask the patient to lie in prone position with head turned towards the right and arms by the side. Then I'll administer oxygen via nasal
You
prongs.
will give bite guard to the patient. Bite guard is given to the patient. Okay.
I'll administer oxygen via nasal prongs at 4 liters. Bite guard is given. Then I'll sedate the patient with injection midazolam 1 milligram, injection ketamine 20 milligram, and titrated doses of propofol. Then to ensure the adequate level of sedation, we can try inserting a nasopharyngeal airway and patient will not respond to it. We can then ask the endoscopist to start the procedure and maintain the sedation with intermittent boluses of propofol.
So what are the monitoring that you do? during this procedure, what are the monitoring that you are going to do?
We should monitor respiration mainly
How will you monitor the respiration? What are the parameters?
by ECG or pulse oximetry, impedance by
It is respiration by monitoring that you have put an ATCO2.
ETCO2.
Ah.
ETCO2 has been attached, but it's not may not be reliable as we are using carbon dioxide for inflating the
what-
gastrointestinal
how
tract.
it
But
can
we can
help you? How it can help you?
but we can know the trend
Trends,
and
yes.
respiration.
Trends of
Respiration.
apnea, whether the apnea is happening or whether there is hypercarbia. Okay, that you can monitor. And about any respiratory rates by means of ECG, impedance.
Impedance biometry, madam.
So that will help you to know the respiratory
Respiratory rate.
rate also. So what problems can happen during this time? Suppose the patient becomes apneic or hypopnea. What will you do?
If the patient become apneic, I'll first increase the flow of oxygen. Since we are using short acting drugs, patient may recover spontaneously. We can try giving jaw thrust. If the apnea is not resolving, I'll connect an vein circuit to the nasopharyngeal airway with the help of an 8 mm connector. And I can assist the respiration with the help of veins.
Okay. So you increase the flow of oxygen.
Yes.
Put a 8 mm catheter through the nasopharyngeal airway and connect it to a breathing circuit. You can also apply jaw thrust. So, since you are giving short-acting drugs and propofol intermittent doses, so it doesn't usually cause much problem. So, when can it cause problems? Because you are using a combination of drugs, like you can use fentanyl, you are using ketamine, you are using propofol. So all these act together can cause respiratory depression. So you have to be careful. So you are giving, what is the plane that you give? You are giving monitored anesthesia care.
We require deep sedation for ERCP.
So what are the different stages of sedation?
Levels of sedation include minimal, moderate, deep, and general anesthesia. It's classified based on the responsiveness of the patient, airway, spontaneous ventilation, and cardiovascular function. In minimal sedation, patient usually respond to normal response to stimuli, and airway, spontaneous ventilation, and cardiovascular function will be unaffected. In moderate sedation, patient responds to purposeful response to verbal or tactile stimuli. Then airway usually maintained, spontaneous ventilation is maintained, cardiovascular function is also maintained. In deep sedation, the patient will respond only to repeated painful stimuli. Spontaneous ventilation may not be inadequate, airway may not be maintained, may require intervention, cardiovascular function will be maintained. In general anesthesia, patient will be unarousable even with painful stimuli. Spontaneous ventilation is not maintained and requires intervention, airway also requires intervention, cardiovascular function may be impaired.
So what is the role of anesthesiologist in monitored anesthesia care? You can just explain what you have said now.
We have to have a thorough monitoring all throughout the procedure. Then we'll ensure analgesia, sedation, and if it is necessary, we have to intervene if there is any problem during the procedure, so that the person can do both therapeutic and diagnostic procedure conveniently.
Okay. So
What is the usual duration of ERCP?
It's about 30 to 45 minutes usually.
what is the position? Position of the patient for ERCP.
ERCP can be done under prone, lateral, or supine position. Prone position is usually preferred as it helps in optimal visualization of the structures to the endoscopist.
So commonly done in prone position. When can it be done in lateral position?
If there are any contraindication for the prone position like tense ascites, pregnancy, anterior abdominal wall surgeries, cervical spine problems, we can do in left lateral position.
Or even post-op patients we can do in supine position.
So what are the problems if ERCP is needed in a pregnant patient? Or what are the guidelines actually?
Okay. Pregnancy itself is a increased risk of cholestasis, cholelithiasis, so patient may come for drainage, and we can try doing it in the second trimester. Second trimester is usually preferred as the fetus get exposed to radiation. And if the fluoroscopy is done, we can reduce the dose to less than 5 rads, minimize the number of fluoroscopic images, and protect the pelvis with the help of a lead shield. And we can also go for non-irradiation techniques like confirming the position by aspiration of of the bile through the catheter. And an experienced endoscopist should done the procedure, and we should also do fetal monitoring.
And it should, first you have to be definite about the cause, whether it is actually needed, indicated or not. You can put a stent and then definitive surgery can be done after delivery of the baby.
What if most centers it's done under general anesthesia with endotracheal intubation, controlled ventilation? How will you proceed with that?
So we can pre-medicate the patient with injection glycopyrrolate 0.2 mg IV, injection midazolam 1 mg IV I'll give, and then I'll give injection fentanyl 50 microgram IV, and then I'll do a pre-oxygenation with 100% O2 for 3 minutes, or if EtO2 is more than 90%, and then I'll do induction with injection propofol in slow titrated doses till I'm getting a lack of response to oral stimuli, and then I'll confirm the ventilation. Once it is confirmed, I'll give injection atracurium 25 mg IV, and at 4 minutes I'll do a direct laryngoscopy, intubate the patient, and then after 5-point auscultation I'll fix the tube, and then the maintenance is done using oxygen, air, and I'll go for a total intravenous anesthesia.
Why did you choose atracurium in this patient?
Atracurium metabolism is by Hoffman's elimination. It does not undergo any hepatic metabolism, so it's better to go for
So
that.
you have talked about the anesthetic complications. What are the procedure complications that can happen in ERCP?
Procedure-related complications include bleeding, perforation of the bile, post-ERCP pancreatitis, iodinated dye allergies.
So post-ERCP pancreatitis is very common. What do the surgeons give to prevent post-endoscopic pancreatitis?
What is the cause for this post-ERCP?
Post-ERCP pancreatitis occurs due to the mechanical irritation of the pancreatic duct, and also due to chemical nature of the iodinated dye and high pressure injection of these iodinated dyes.
So what is the drug
It can be
given?
managed best with NSAID, that is diclofenac.
Usually these gastroenterologists, they will give non-steroid suppository, indomethacin or diclofenac suppository to prevent.
You told carbon dioxide is used for insufflation. So do you anticipate anything during extubation or awakening of the patient?
Abdominal distension can.
Any delayed hypercarbia can result in delayed awakening of this patient. And how will you know after this procedure? How will you know that the decompressive procedure is effective?
We can check the total bilirubin and delta bilirubin values. Total bilirubin will decrease, but the fraction of delta bilirubin will remain high.
What is delta bilirubin?
It's the conjugated bilirubin which is bound to the albumin. Since the half-life of albumin is around 21 days, it takes around 21 days for the delta bilirubin fraction to go down.
So both of you, Dr. Gloria and Dr. Ammu, both of you have done well, and I also congratulate the faculty who have trained them. Okay, thanks.
Thank you.
Thank you for this wonderful session.